or management in another way to stop them becoming the overall reported position. Those have broadly been moving in the right direction, as you can see, coming down between month 4 and month 5, and we do expect further improvement between month 5 and month 6. The one I would just draw attention to, though, which is an area of concern, an area of national concern at the moment, is what's described there as prescribing prices. So this is it's a horrible term, but NCSO, no cheaper stock obtainable, which is around generic drug prescribing, basically. Problems with supply chain nationally, internationally around that is starting to push the price of prescribing costs up a little bit. As I say, it is a national issue, and we do need to watch how that's growing and our ability to manage that, but there's little directly to influence that, other than the focus which we always keep on trying to use generic drug prescribing where it's all possible. That's all I need to say, but I'll pause for questions.
Thank you. So does anybody want to raise any questions? John, first report. Did you want to?
Well, I suppose just as chair of finance committee to just to support what John has just said, really, in terms of the significant risk there is in the system, not just in terms of a very, very challenging cost improvement programme, but inflation pressures and the generic prescribing issues that John's just highlighted. We have asked for some further detailed update on all of that for the next finance committee meeting at the beginning of November, so we'll be able to report as John says, the next stage of the work on this into our November meeting.
Thank you. And any other questions from colleagues? Anything further you'd like to say on second?
So yeah, if I could please, Chair. Sorry, again, conscious of time, but so turning then to the report for the same period to the end of August, but for the wider integrated care system, as I said, the partnership of 5 organisations, NHS organisations across Devon, a slightly more complex picture to report on. So just to a few introductory comments on that. So across the wider Devon system, as the exec summary says, just a reminder, we submitted a deficit plan, so we couldn't quite get to break even across the system at the planning stage. 18.2 million deficit plan submitted, but with an acknowledgement that we should continue to work to get as close to break even as we possibly can. That remains the commitment, the ambition from the system, but there is significant challenge to the delivery of both the plan and, by extension, the chances of getting better than plan are certainly diminishing. Again, parallel with the ICB report, the efficiency savings requirement across the whole of our system was significant, 138.9 million, which is in the region of about 4% of the total expenditure that we have on health services in Devon. So at month 5 for the wider system, again, we are slightly behind plan, so an adverse variance of 3 million against the planned deficit position of 11.6, which is a deterioration compared to month 4. So this is moving slightly in the wrong direction. We do, however, continue to forecast that we will recover that shortfall and deliver to the 18.2 plan at year end. I will move us straight on, if that's okay, to just pull out the risks and mitigations table, which is included. So again, similar to the ICB, this is acknowledging that there is a significant amount of financial risk and uncertainty which would challenge the delivery of that 18.2 million deficit. We acknowledge a lot of this at the point that we submitted the plan, and I can say positively that it is moving in the right direction. So as that table shows, the overall net risk has reduced by 13 million in the month and now stands at 66.7. That's a risk to delivering the break-even position. The risk to delivering the plan would be 18.2 million less than that. So it is moving in the right direction, but still significant. The most significant of the risks that we have identified there is that we fall short of that original requirement of the 138.9 million savings. So our financial recovery efforts to recover that position is still very much focused at pushing both through individual organisation governance processes, but also using the system governance processes to improve the rate of delivery from the CIP programmes that we had in the first place. We are supplementing that with a number of additional actions at system level, and the rationale for that is really to not fall into the trap of thinking of ever increasing number of things to do and delivering none of them well. So we are trying to focus on the things that we identified in the first place and get the maximum effort behind that, rather than coming up with a range of different things. Again, that's probably all I need to say by introduction, Chair, but I'm sure there will be some questions.
Again, shall I come first to you, Kevin? Judy wants to.
Just to say the same thing, we have nothing to add to John's very thorough summary there, but the financial recovery plan will be the main item on the next agenda of the Finance Committee in November.
Thank you. And Judy.
So I have two questions, just where I may have forgotten what I've been told before, my apologies. But I do think, as a general comment, we need to decide whether our plan is 18.2 deficit or our plan is break even. But I think the language which says we're delivering to plan, which is 18.2 deficit, which the region have told us they don't expect us to end with, is a very confusing plan. So somewhere we need to be getting that language right. And John, thank you, because this time you've made it much more clear when you're talking about the plus or minus 18.2. Could I just ask, I'm not sure what work stream stretch is. I'm looking at there's no page number, but it's in the efficiency plan for the different areas where there will be efficiencies. And forgive me, I have forgotten what the 7.7 efficiency in primary care is about. I knew there was a little bit being taken out to repay the subsidy when delegated commissioning did not cover us well enough. But I'm a little unclear what that 7.7 in primary care is.
So two questions in there, I think, Julie, and also just to acknowledge, sorry, the messaging around is it 18.2 deficit or break even is slightly nuanced, which is difficult. I know the first responsibility is to deliver the plan, so 18.2 deficit plan. If we can get better than that, that's the expectation. But first responsibility is to deliver the plan, hence why we're still reporting against both. And you can take from my report that the likelihood of getting beyond plan is slim to none. So first responsibility clear. On primary care, there were savings and efficiencies targeted from all of the areas that we do commission. So it was important that primary care made a contribution to that. A lot of the expenditure that we make through primary care is contracted and subject to national terms and conditions. So it's not targeting that area. Some of it is more discretionary around enhanced services, as we term it. So that's the area from which that would have come, and that has been delivered at the point that we set our budget and reached the agreements with primary care.
So it was taken out in advance.
Yes.
And therefore we've been working with a lesser budget. Okay.
So John, I think it's prescribing, isn't it? The majority of that 7 million. So it's on it's on slide 6. So if it's not, that's what I think it is, Judy. That's what I've been working 2, because meds optimisation is not shown in the ICB line otherwise. So I think it's that, Judy.
If it is, John just said that's most at risk.
I don't think the meds plan's at risk. I'd feel comfortable about that.
Linking it into the point about pressure from prices on NCSO is what so on the one hand, there's a programme of efficiency targeted which is
on track, yeah.
But it could be knocked off course by price increases. That's the point.
I'll take this outside the meeting to make sure I understand.
We'll clarify where meds optimisation sits as part of primary care.
Thank you.
Thank you. Yes, Frank.
So the document you sent us from the National Audit Office looked at our plan and said none of it was low risk. It was either medium or high as far as I looked from that document. And that was before all the financial pressures that every organisation is going to be under. So I think this is going to be much more challenging as we get further through the year than actually free at this point in time.
Yes, I think so. Any other clouds on the horizon as well? But are there any other questions? No. Thank you very much again, John, for everything you've done. Thank you. So we're now going to come on to a presentation on planning and assurance for winter, and over to you, Nigel.
Thank you very much indeed, Chair, colleagues. I want, on the slide deck that you got in front of you, I just want to give a little bit of introduction and context, picking up perhaps on some of the things that we've heard already today. So our ambition, it's been an ambition in the NHS for some time, is to try and reduce inpatient stays where possible and convert those to day case, and where possible to convert day case into outpatient, and for people to spend time in hospital only for things that can only be delivered to them in hospital. And that fits with our kind of right care, right place, right time, and also links to what we heard from John about the bed base. I'd also like to acknowledge formally, if I may, the amazing work that colleagues are doing right across the voluntary sector, social care and health system at the moment, not only in the work they're doing day to day, but also in helping us with the plans that are outlined at a very high level, as I described the process for assurance into winter, and we're really immensely grateful for that support. And on that first slide, some additional challenges that we've got relating, I'll put some numbers in regarding COVID and the patients currently in hospital for COVID. Yesterday, that number, in fact, had reduced slightly to 215, but clearly there's an uncertainty about flu and other respiratory illnesses as we approach winter, and that's one of the contexts that we're trying to manage. And the other relating to the ambition that people are only in hospital for those things that can only be delivered in hospital. The reality currently is that we've got quite significant percentages of hospital beds with people for whom they're not having treatment that's required in hospital, and we are trying obviously to find ways of supporting them to be discharged from hospital into a more appropriate setting for their needs. But that remains significant, and the numbers are included. If we move to the next slide, what we can see in terms of those demands that we see over winter each year, what that would mean in terms of an additional demand on bed numbers or bed equivalence bed numbers over the period, and that's outlined and broken down by trust. And then moving on to the next slide, some of our mitigating actions that we've put in place to try and manage that. And for that, we have received some funding in order to try and reduce that. Now, because of the lack of physical beds, what we're talking about, and Liz mentioned this earlier on, is bed equivalents. In other words, how can we manage people differently, avoiding the need for them to be in a physical hospital bed. And on top of that, we have taken some of the money that we've received to achieve this to specifically address the problems of long ambulance waits, as one of the trusts. UHP is one of the trusts nationally where that issue of very long delays for people in the back of ambulances outside the trust has been an issue. So that leaves us some funding more generally to to focus on a number of areas. Now, broadly, those are some escalation beds, some physical beds, so that we can provide those and also help the flow through hospitals, which is one of the key areas. So broadly speaking, we've got work going on to try and support people in their home or community setting. And hopefully avoid admission. And one of the pieces that Hisham just talked about was, how will we be able to describe success as a system, and picking up also what Judy said around the virtual ward, which is a way of trying to help people be managed in a community or their own home setting, avoiding hospital care at a higher acuity, if you like, than we've been able to do up to now. We are trying then to support flow through hospitals. We're trying to support discharges and also recognise the impact, and Sarah alluded to this, of people with mental health problems, how in an urgent and emergency situation they are able to receive care. And one of the big areas of focus for us has been and will continue to be how we use our NHS 111 system as a way of helping people to navigate to the right support and care that they need when they need it. So in terms of picking up one of the things that Judy said, how do we know, what's happening in terms of some of these areas that we're trying to support and bolster? We've got a trajectory here for when we think the additional capacity in terms of that high-level bed equivalence will come on stream. And that's important because on the next slide, and apologies, it's slightly busy, it's got the line of that original bed equivalence that we think we need to try and mitigate. So if we go on to the next slides after that, Jodie, because it's got that combination of the bed equivalence and also the actions that we're taking to mitigate that, you'll see that there is still currently a gap. And one of the biggest gaps that you'll see in terms of the mitigating actions that we're putting in place and that bed equivalence is in November, which is when we feel that demand will be high, but not all the mitigations that we're planning will be in place. So the next slide is some of the other actions that are both agreed and underway and planned for the next couple of weeks in order to try and bridge that. So Andrew and his team very, very grateful for that communications to the public. And one of those messages is around we are trying to encourage everybody who's eligible to take their flu vaccination and their COVID booster, as Jane mentioned in her chief executive report. And that piece of work is really important because what we want to try and do is offer protection not just to the people of Devon who hopefully will then that'll reduce their risk of needing support, but also for our staff, because one of the knock-on impacts when we see either waves of COVID or flu sweeping through is that it adds pressure onto all of our services through staff absence, through their own illness. What we have also been doing is we've started an expansion of the ambulance catchment population or geographical footprint around the Royal Devon University's hospital for a finite period of time in order to try and reduce some of the pressure that we currently see around the Plymouth system.